Keith.
Good morning, my lady. The first witness today is Simon Ridley.
I do solemnly,
Sincerely and truly.
Declare and affirm. That the evidence I shall give. Shall be the truth. The whole truth. And nothing but the truth. Thank you, please.
Could you commence your evidence, please, by giving us your full name?
Simon Allen Ridley.
Mr. Ridley, thank you for attending this morning and also for your provision of two statements. One, 252-914, I think it runs to about 97 pages. You produce over 453 exhibits, or at least you refer to them. You've also provided a corporate statement together with James Bowler, there we are, the second permanent secretary of the Cabinet Office, to do with matters concerning the COVID task force. My lady, it may be worth saying that, of course, both those statements and all the documents and exhibits to which Mr. Ridley refers will, of course, be put onto the website and considered, as with all the other documentary material before this inquiry. Mr. Ridley, you joined the civil service in 1997, is that correct?
Yes.
And you were initially with then Her Majesty's Treasury until 2010?
Yes.
I think you then moved to the Department for Communities and Local Government.
Yes.
In 2014, you were appointed Chief Executive of the Planning Inspectorate of England and Wales. You then moved back to the Department for Communities and Local Government.
Yes.
In 2019, you joined the Department for Exiting the EU. And then you moved into the Cabinet Office in January 2020.
That is correct.
In January 2020, you established, we understand, the Transition Task Force, which prepared for the UK's exit from the European Union. Formerly, the United Kingdom left the European Union, of course, at the end of January 2020. Was that preparation and the task force concerned, therefore, with the end of the transition period, which ended in December 2020?
Exactly. The Department for Exiting the EU was closed down at the end of January 2020. There was a team under Lord Frost negotiating the new agreement. My role alongside Jess Glover, colleague in the Cabinet Office, to set up the Transition Task Force, which was to prepare sort of, if you like, UK side for the exit following the agreement with the EU.
And the exit culminated, did it not, in the signing of the Trade and Cooperation Unit on the Trade and Cooperation Agreement on the 30th of December 2020?
Yes.
Right. Of direct relevance to this inquiry, were you asked on the 16th of March of 2020 by the Cabinet Secretary to become Secretary to what was then the newly established Healthcare Ministerial Implementation Group?
I was.
What was that?
On the 16th, I had a meeting that morning with Mark Sedwell. His proposition was to restructure and hugely increase the capacity of Cabinet Office to respond to the COVID pandemic. And wanted to set up 4 new decision-making groups, ministerial implementation groups, along the key 4 areas, of one of which was healthcare, which was the one he asked me to be secretary for. Those 4 groups would then, if you like, feed up to a strategy meeting that the PM would chair, which happened at 9:15 most days. The role of the Health Ministerial Implementation Group, or HMIG, was to take decisions on the government's response across all the areas of health and social care. I mean, it was a cabinet decision-making committee My role as secretary was the standard cabinet office role in terms of preparing with the chair, who was the Secretary of State for Health, for the meetings, to make sure that there were papers for the meetings, to note and minute the meetings and the decisions that were taken.
Were there, in fact, 4 MIGs, Ministerial Implementation Groups, of which healthcare was only one? I think there was general public services, there was economic and business, and then finally international.
That is correct. Each chaired by a separate Secretary of State.
And each of these areas was meant to replicate the broad strategic areas of interest within central government, particularly within the Cabinet Office, in order to be able to put a structure for the governance and the strategic and operational decision-making for the response to COVID into place.
Yes, I mean, it was clear this was a whole of system crisis, and we need to be able to respond across all of those lines of operation.
All right. And just to look for a moment at the areas that your MIG, healthcare MIG, addressed, it addressed matters such as NHS capacity, shielding, social care capacity, the public health elements of the response to the COVID crisis, and it was both a strategic and operational body, so it strategized and it advanced proposals for operational matters.
Yes, that is correct.
All right. I think your statement shows that you, in fact, if we can have paragraph 11 of 252914, you coordinated wider advice on healthcare issues across the Cabinet Office, and you attended a large number of strategy meetings chaired by the Prime Minister. You obviously attended meetings of HMIG, and throughout the course of the remainder of the year, or at least until the HMIG system ended in May, you were exclusively concerned with being the secretary to that particular organisation.
Yes, that's correct. I mean, the point to note is an awful lot of the healthcare response was obviously central to the work that was being done in that period between March and May, and so a lot of issues went to the 9:15 meeting rather than HMIG, when they were things the Prime Minister was particularly focused on.
All right. Now, I want to start by looking at one particular aspect of the work done by the Healthcare Ministerial Implementation Group, which was the shielding programme. Was there an early and particular focus on shielding around the time of the decision to impose that first national lockdown, so mid-March?
Yes. I mean, when I came into the COVID response as Secretary to HMIG on the 16th of March, alongside just setting the committee up, agreeing the terms of reference with the chair, the first and main substantive item I was focused on was shielding.
Give us an understanding of the scope of the problem or the crisis faced by the government in terms of making arrangements for those persons who were required to be shielded. How many people were assessed to be medically vulnerable and therefore primarily in need of shielding support?
So, I mean, I think it's firstly, I think we didn't know with any great certainty. I mean, in the sort of low millions, that sort of order, and there was a question, which was indeed a question for much of the period, about how large a group of people the shielding programme should apply to. And as we went through the period, there was a group of the sort of so-called clinically extremely vulnerable, but there was a much wider group of people with increased risk, but where the balance was slightly different.
So there was a constant debate about the need not just to address the needs of those who were clinically extremely vulnerable, but those who are socially vulnerable, those who generally needed support, those who may or may not have made themselves known to GPs and to hospitals, and therefore a real need to try to identify who you should be addressing your support structures towards.
Correct.
All right. Were you in contact with the devolved administrations in relation to shielding, or was this an England-only issue as far as HMIG was concerned?
So we were setting up the shielding programme in England because public health and those issues are devolved across the UK, but we were in touch with the devolved administrations. I certainly had calls with official colleagues, and I think they joined a number of the calls we had in those first couple of weeks as we set it up.
Could we have 197987 on the screen, please? This is a document dated the 17th of March. It's a note of an update meeting with the Secretary of State, offer on vulnerability. I just want us to get an understanding of the complexity of the issues. If you could just scroll back out, we can see that there are references to the core principles and eligibility, which of course had to be decided, Mr. Ridley.
Yep.
The operating model, how it's going to work in principle, what the role of the NHS would be, how it would work vis-à-vis GPs, how the voluntary community sector would work, DEFRA, and military planning and so on. So it was an extraordinarily complex exercise.
Yes, and I mean, my role in it was to bring senior colleagues from across government together. This was a programme that needed significant infrastructure and capability built by a number of departments. So there was DWP, I think, set up the call centre, MHCLG, the Ministry for Housing, Communities and Local Government. We're working very closely with local authorities in terms of a lot of the practicalities of setting up the system. DEFRA we're working with supermarkets to how to get food deliveries to people who were shielding, because the whole point was they couldn't get out to do their shopping. NHS were very involved and indeed wrote to all the individuals on the shielding list, enormous sort of printing and letter runs. We had through the week of the 16th, we were establishing that programme, those different lines of work, and keeping everybody together in order to ramp that up so that it could be announced as we went into and in the week of the first national lockdown.
What was the genesis of the shielding programme, Mr. Ridley? The decision to impose a mandatory stay-at-home order wasn't, of course, made until the 23rd of March. But it's clear from the paperwork that the programme for shielding scaled up at pace from the week before. So the week of the 16th, you're engaged in trying to put the programme into place. What led to the programme being commenced in that way? Was it a reflection of the fact that social distancing measures had been put into place on the 16th of March, or was it a reflection of the fact that there was an understanding on the part of government that a lockdown was inevitable and therefore necessary preparations had to be made?
So I don't think, speak with authority about the genesis of it, because I think the genesis of shielding was prior to the week of the 16th. In fact, when I joined, there were people in departments thinking about aspects of the programme. I mean, I think it came from a realisation, as I recall, that as social activity was reduced, there would be, a cohort of vulnerable people who would need particular support with higher risk factors, who would need to stay at home much more, and what was the support structure around that cohort.
Right. Could we have 197984? This is an email dated the 17th of March. It gives some indication of the number of bodies who were concerned in this programme. It's an email from the Cabinet Office on behalf of yourself, Mr. Ridley. and it sets out a list of actions and a list of agreed products. For a COBRA meeting, those actions are due by the close of play that particular day, the 17th of March. So the process was moving at pace, as I say, at full speed early on. We can see the list of actions at the bottom involving the DHSC to confirm public health policy, a breakdown of 1.4 million people to confirm a critical path for preparing and sending letters, and then over the page, actions for the DHSC, for the Ministry of Housing, Communities, Local Government, DCMS, DEFRA, DWP, BEIS, the Home Office, the MOD, and HMRC. So a lot to be done.
Yes, I mean, this was very much a whole of government programme.
We can get some idea of the numbers and the scope of the programme from 198016. This is a shielding offer comparison. Was this a reflection of the category of people who may need to be engaged in the shielding programme, who may need support of some sort, as well as the numbers of persons across England, Scotland, Wales and Northern Ireland who could potentially be engaged?
Yes, yes it is.
Right. So a massive undertaking.
Yes, and in addition to this, as we opened up the website where people could refer into it, the numbers grew because a lot of people self-identified beyond the lists that we had originally.
And there were a couple of major issues, were there not? Firstly, having initially identified those who were clinically extremely vulnerable, it rapidly became apparent that there were other people who needed support, and that was obviously a cohort, a large number of people in addition. And also that there were a number of people who had self-registered rather than being put onto the list of persons who required shielding by their GPs or by other local authorities or government bodies. So you had to work out what to do with them.
Yes, we had a kind of comprehensive, inclusive approach to this, which enabled people to, as I say, self-identify, GPs to put people forward as well as the original lists we had, and that grew the numbers substantially.
And again, in reflection of the speed at which you worked, a call centre went live on the 25th of March, and by the 29th of March, you'd been able to work out plans not just for those who are clinically extremely vulnerable, but also for non-shielded vulnerable people as well. So the programme expanded as well as moving very fast.
Yes, that's correct.
All right. There were a number of other areas that the Healthcare Ministerial Implementation Group addressed. Did they include NHS capacity? So was an important part of your work maintaining oversight on what the NHS capacity was and how we would be able to respond to the demands placed upon it?
Yes, that is correct. I mean, at this period with the level of infection growing very fast and the numbers of people going into hospital fast, the ability of the NHS to have the beds and the ventilators for that was a kind of critical focus of the time. That was in the terms of reference for the HMIG. Quite a lot of those discussions also happened at the 9:15 meetings with the Prime Minister.
Number 10, Downing Street was constantly seeking, was it not, from HMIG, data about hospital capacity, how many hospitals were at risk of being overrun, what the progress capacity was of the Nightingale Hospital Scheme, and so on and so forth. So there was a constant imperative, if you like, to keep Number 10 up to date and informed as to what the state of play was.
Yes, I mean, I think at the beginning of the period there was an enormous need, I mean, for the Prime Minister, for the Cabinet Office, for government as a whole, to have clear, consistent data of the position on a whole range of things, including hospital capacity. I mean, what we did just in terms of the Health Ministerial Implementation Group, we took at the beginning of those meetings the dashboard as it was at the time, on the same basis that it went to the strategy meetings in the morning. We tried to use some of the actions from those meetings were to improve that data as we went through.
And it was made clear, wasn't it, that the Prime Minister was particularly concerned with the need to obtain and get access to or procure a large number of ventilators. That was a constant theme, was it not, throughout the middle of March and the beginning of April?
Yes, it was.
And was a lot of HMIG's time spent procuring ventilators, conducting meetings and calls in order to accelerate domestic production, obtain ventilators from abroad, and so on.
So, I mean, not precisely. I mean, so the health MIG itself was a meeting, so a sort of ministerial decision-making meeting chaired by the health secretary, and could look on issues at, how do we? The purpose of it was to drive forward decision-making to make progress against these areas in concert with the other MIGs and with the PM's meeting. My team supported that committee and made sure that the work across Whitehall was done to provide the papers and the decisions for ministers to enable that to happen. Procurement of ventilators was not something that my team did. There was a lot of work between the commercial teams in the NHS and I think DH and the commercial teams in the Cabinet Office to work with industry and to try and drive the capacity in the country to increase the ventilators that we.
So you were in charge of the strategy and you were driving the process from the central government end of things, from the Cabinet.
Exactly, but I did not have responsibility for procurement or some of those practicalities.
In relation to the issue of discharge to social care, were the practical arrangements for the discharge of patients from hospital to the care sector made by central government, Cabinet Office, or the DHSC?
So that was very much work, I mean, in the health system between the NHS, local authorities and the care sector. In central government, that's the responsibility for DHSC, working very much with the Ministry for Housing, Communities and local government, given their responsibilities across local authorities. Again, our job in the Cabinet Office was to convene, bring people together, understand the position in the round, and then use the HMIG as a means for government to make cross-government decisions where it needed to.
And was that where the decision was made or advice was given as the decision to be made about the discharge of patients from hospital to the care sector?
So I think the need. So discharge from hospitals to the care sector is something that happens as a matter of course outside the pandemic. Of course, it was particularly important in that period that people who were ready to leave hospital and NHS beds were able to be discharged. So in a sense, that's part of the operation of the health system. I think the importance of it was discussed in HMIG. It was also an important part of meetings with the Prime Minister at the strategy meetings, and I think the aim, I can't remember the precise time period, I'm afraid, but the aim was that my recollection is there were an aim to get 15,000 people discharged from the NHS into social care over that period at the end of March and beginning of April.
And this presumably was one of the many areas of focus for HMIG. This was discussed repeatedly at meetings throughout March and April.
Yes, certainly in March and the first part of April, HMIG focused on the progress being made towards that end and the issues around it in terms of the preparation in the care sector for receiving people.
This is obviously something for a closer attention in a later module, but I just want to set out the chronology in the broad structure. Was there an HMIG meeting on the 22nd of March 2020 where social care was considered? 55942.
Yes.
We can see at the top, Covid-19 Health Ministerial Implementation Group, Sunday the 22nd of March, 10 a.m. A number of ministers present, chaired by the Secretary of State for Health and Social Care. Over the page, we can see your name, second name down. And then if we go through, please, to page 3, we can see the bottom indent, the last paragraph on the page. The following points were made: to support capacity, thank you, in community care, advice to care homes should be updated. Current guidance suggests they should accept patients who are asymptomatic, even if they've not received a COVID test. So, as at that date, the 22nd of March, it was generally recognised, and there was guidance to this effect, that patients would be accepted if they were asymptomatic, but had not received a COVID test, in fact.
Yes, I mean, at this time, there was a lot of work going on in terms of amongst the scientists and the medical community about asymptomatic transmission. I think Said were discussing these issues. I think I point that out in my statement. In HMIG, as I say, the purpose of these meetings was the progress on discharge and the issues around it, and that included, as this note says, the capacity in community care and the issues around receiving people from hospitals, which included testing at that point.
The two most important features of this policy, or the guidance, Mr. Ridley, were firstly that no assurance had ever been given that patients would be moved only following a negative test. That's simply not what the guidance and the position reflected. And secondly, that there was a constant debate as to whether or not there was a need for testing and whether or not the system practically allowed for the sheer number of tests that would be required in order to test patients coming out of hospital.
Yes, I think that is correct. There was a balance of different issues and different needs, and we did face some capacity constraints at that point, which the NHS, the care sector, and DH were grappling with.
Could we have 198032? This is an email on the 3rd of April from an official in number 10, Alexandra Burns. She addresses it to team, and from the fact, Mr. Ridley, that you responded at the top of the page, we'll come to it in a moment, you must have been amongst the recipients. I know that social care is front and centre of a range of conversations that are happening on, for example, PPE or testing, though of course is always second to NHS. Do we know whether there is coherent overall strategy for care homes in either DHSC or in the Ministry of Housing, Communities and Local Government, or between them? It feels like maybe we need one in the way that we have one for the NHS. And then she refers to the resources for supporting NHS and capacity, but in relation to social care, what is said in relation to the policy approach appeared to her to be perhaps deficient, enhancing adult social care resilience by maintaining and increasing workforce, maintaining capacity, extra funding, capacity tracking. I wonder if this really covers it. And she says this, just looking at some of the stuff coming out of the rest of Europe, and it feels like something we need to be properly ahead of, given that once someone gets it in one of these places, many die. I'm wondering whether we've considered more extreme measures of guidance or guidance on staff rotations, for example, and then over the page. I'm checking with you guys because I'm aware that it might just be something that's happening that I haven't seen. For example, is the healthcare IMG looking at it properly? So that's your MIG. I think she meant to say Ministerial Implementation Group. And was there a realization at this time, the beginning of April, that perhaps by contrast to the approach to the NHS, which of course had been first and foremost in the government's consideration terms of the need to protect it, there had been perhaps an absence comparably of focus on the care sector.
Well, I mean, I think we were certainly in Cabinet Office and in number 10, as Alex's email shows, at the end of March and April, concerned to understand the position in care homes. And we've just discussed the healthcare MIG discussion of it on the 22nd of March. I think it is true those concerns were growing as we went into April. The data and the information around care homes was less good because the nature of the sector, a very large number of care homes, many very, very small, and as Alex's email says, really keen to make sure and assure ourselves there was a broad and coherent plan across the piece for care homes, but through those MIG meetings, the very significant issues weren't coming through, and we were wanting to test that.
On the 7th of April, 83702, there was another Health Ministerial Implementation Group meeting held at 12 p.m. We can see a large number of ministers and members of Parliament attending. Over the page 2, your name can be seen in the middle of the page, along with a number of other officials. And then page 4, on the 3rd and 4th paragraphs, there is a reference to the Minister of State for Care. Was that Helen Whately, MP?
Yes, it was.
I think your statement, in fact, refers to the Secretary of State at paragraph 71, but it was, in fact, the Minister of State for Care. She said, ensuring parity in the approach between the NHS and social care for PPE and testing was important. PPE was being delivered to social care providers from national stocks. A new channel was also being established to provide PPE to social care providers. Then this social care workers were also to be tested alongside NHS staff where capacity permits in order to reduce staff absences. And just before you answer, if we can look at page 5, we can see the actions, and they include work on metrics for adult social care, the need to ensure data reporting compliance from care home providers, and then it says this, work on discharges was welcome, that must be discharges from hospital, and the number of patients for the hospital stay of over 21 days had halved. So concerns were being expressed, were they not, as to whether or not there was a problem with the movement of patients from hospital to the care sector in terms of whether or not they were infected with COVID, and steps were being taken to ensure a proper understanding of the position and whether or not testing would be available in order to be able to address that problem.
Yes, I mean, I think that is correct. I mean, as other of these actions show, we were also concerned to make sure that the funding and support was there for care homes, which Ministry of Housing, Communities and Local Government was working with local law authorities in terms of managing, financial resilience. The care sector, as you'll go into in later modules, I'm sure, is very diverse and dispersed, with some larger care homes, but also some very small enterprises.
Is it fair to say, Mr. Ridley, though, that a number of people expressed quite serious concerns, though, about the fact that, firstly, patients were being discharged into the care sector without a negative test, without, of course, assurance that they weren't infected with COVID, and secondly, that there was an absence, in essence, of testing of workers in the care sector and also of patients already within the care sector?
Yes, I think it is certainly correct that concerns were being raised on a number of issues around the care sector, and there certainly were constraints in terms of the testing that was available and used.
Could we have 198042? On page 1 at the bottom of the page, a Cabinet Office official, Mary Jones, says, Chris, I'm just sending this to Cabinet Office colleagues because my knowledge of social care is very limited, so others with more expertise should editorialise anything I say here. And then over the page, she refers to a number of concerns that she has in relation to the approach being adopted to the problem of testing, of patients within the care sector and residents in the care sector not being tested for COVID, and of course on the fact that many workers in the care sector had not themselves also been tested. To what degree did HMIG appreciate that there was a very serious problem with, of course, the spread of the infections throughout the care sector?
So I think the ministers and official colleagues at HMIG were concerned about the position in the care sector, concerned about the relative lack of data and information we had, and concerns around the risks of spread of infection, whether between patients or between workers and patients, and was seeking in various ways, as we've just discussed, to try and tackle those issues and put policy and operational guidance in place.
Was there a concern expressed by some within your ministerial implementation group that the DHSC was not doing enough to help, or that it was in a general sense behind the curve?
I think in the centre we were, as some of these emails demonstrate, concerned about whether there was a comprehensive plan for how government would support and minimise the risks in the care sector. I think that work was being done in DHSC and elsewhere, and a strategy for care was produced in the middle of April, about which again there was some debate. But I think yes, we were concerned that there were problems in the care sector that needed to be addressed extremely quickly.
There was a general absence of planning within the DHSC to meet this problem and to meet this issue.
I don't think I can say with authority what planning there was and wasn't in the DHSC on this issue. It was certainly the team responsible for social care was, working incredibly hard, relatively, I think, stretched. And as I say, we were pursuing these issues through HMIG. That strategy came forward in the middle of April.
In terms of the practicalities, in terms of providing a sophisticated and comprehensive test system to ensure that patients were not discharged from hospital into care homes when they were infected, and also to ensure that patients and workers did not move around within the care sector whilst infected, the Cabinet Office and Number 10 and the HMIG body had to push the DHSC to say what is going on, what is being done about this, what can be done to solve these very grave problems.
I think, yes, that is broadly correct.
198046. If we could start on page 3. This is an email from Dr. Warner, right at the bottom of the page, 1628, 13th of April. Thank you, and then over one page. Hi, Imran. That's Imran Shafi in number 10 and Tom Shinner in number 10. I'm becoming increasingly concerned about nosocomial infection rates in hospitals, i.e. an infection acquired in hospital. If there's a large-scale infection in the hospitals, then we'll have a number of problems, higher absences in the workforce and further stories about PPE and testing, problems with care homes, including not being able to discharge patients and potentially creating infections in care homes. I don't know where responsibility sits between DHSC, PHE and NHS. And he goes on to refer to SAGE. And his concerns are raised by the splitting of responsibility between different organisations. If we then go back to page 3 and the response to his email, Tom Shinner says, I don't have anyone on this. I think this is a good idea. Yes. And then at the top of the page, Imran Shafi copies you. And then if we go back one page to page 2, I have seen no data on this. We don't have people looking at it at the moment. It's a good idea and we'll pick it up. Could you ask the department, NHS, PHE in the morning and find out who's looking at this? And then at the top of the page, there's a response email from a Mr. McNaught. The DHSC lead is William Vineal. I'll give him a call. And then if we go back one page, finally to page 1, Mr. McNaught says, I've spoken to William Vineal. Is William Vineal in the DHSC?
Yes, I think he is. Paul was one of my HMIG secretariat team. William will either have been in DHS, most likely in DHSC, possibly in the NHS.
His initial reaction was that this is not an issue of concern, but I've asked him to work on a note tomorrow. And Dr. Warner then returns to the fray. A submission to SAGE suggests that around 20% of infections and 10% of deaths are due to infections acquired in hospitals. Given this and the fact that this could cause wide-scale disruption across the government's response, I think it might be worth pushing quite hard on why this isn't an issue of concern. And then Mr. McNaught says, we'll dig around. So 2 questions, Mr. Ridley. Firstly, as the Secretary to HMIG and in charge of HMIG, were you surprised that this had not already been an issue of very grave concern to the DHSC, seemingly?
Yeah, I mean, I think the Paul's report of that call was certainly surprising. I think there was concern about nosocomial infection. It was being discussed in SAGE as Ben reports.
And secondly, when you dug around, or when HMIG dug around into seeing what the position was and why these apparent concerns were not being addressed, to what extent were you able to assure yourself that the DHSC was on top of this problem and was addressing it?
So, I mean, this was an issue, I think, that ran and we continued to focus on for a number of weeks beyond these dates in the middle of April, because I think we were increasingly concerned about nosocomial infection within care homes, the level of infection protection and control in care homes, and the extent to which the sector could address these issues.
In summary, and I say that because this is an issue which will be looked at in far greater detail in the later social care sector module. For weeks, the issue rumbled on as to, firstly, how great an issue of concern this was, what was the extent of the problem, and secondly, there was a dawning realization or an appreciation that the testing system in practice simply couldn't keep up with the policy decision making as to who was going to be tested and who had to be tested. Is that a fair summary?
Yes, I think in just to expand very slightly, I think in Cabinet Office and number 10, we were not assured of the position in care homes and the extent to which there were plans in place to minimise the risks of infection. Testing was a part of that. We were aware of constraints in testing, but there were other mitigations that we were seeking to assure ourselves of, such as broader infection control.
The Chief Medical Officer recommended, I think around the 14th of April, that asymptomatic people going into care homes from hospital had to be tested. And then there were further guidance was produced as to the need to test both patients in the care sector and workers to stop the spread of COVID, of course. Was it the DHSC or was it the Cabinet Office and HMIG which drove the declaration of public policies as to who would be tested? Who was driving the declarations that the time had now come for patients from hospital to be tested or residents and workers in the care sector to be tested?
So responsibility for developing the advice in these areas lay with DHSC, resting on clinical and medical advice. Those were decisions, therefore, that rested with the Secretary of State for Health, though this was an area, as there were with many in the pandemic, where there were trade-offs between different groups when there was a general constraint on testing. So other public sector groups were interested in testing. We had debates about prisons. We had debates about other areas. And so those discussions often came to either HMIG or the PM's meeting for the sort of broader perspective. But so we were driving it from HMIG, if you like, to make sure there was a clear position. Actually, I think similar discussions were had in GPS, MIG, and elsewhere about other groups. The advice came through DHSC, if that is clear.
And lastly, on this topic, again, because we're concerned in this module with central government and the highest level of decision making, is it fair to say that the Cabinet Office, Number 10, and the Prime Minister personally became extremely concerned about the position within the care sector and whether or not policies were being promulgated and publicly announced to the effect that certain people would be tested when there just wasn't in practice the tests available to make good on those policies?
So, yes, there was great concern from the Prime Minister, colleagues in Number 10, the Cabinet Office, about the position in care homes and what could be done to mitigate it. That wasn't just about testing.
No, but my question was, there was concern generally about the care sector and, of course, the vulnerability of the persons within it,
yes,
as well as the discharge policy from hospital to the care sector.
Yes, there was concern about the implications of that, but I think everyone was agreed that we needed to discharge people from the NHS, given the rise in COVID infections and hospitalisations and the need to have space and capacity for them.
The imperative of freeing up space in the NHS by way of bed capacity took primacy over the care sector, the destination of where those patients went.
So that is precisely what we were, what the government was balancing, and yes, it was the case that it was a priority for discharge to happen, and as the HMIG discussions were about what the support and mitigations for care home and the care sector were, there were some limitations to that in terms of testing capacity.
But it wasn't a balance, was it?
Well, ultimately there needs to be a decision. Sorry.
The primary obligation was to free up space in the NHS, and that was done, but without, because of the exigencies of time and capacity, a full understanding of what the impact would be on the care sector, in relation to which there was, firstly, no policy of testing, and secondly, no practical means of ensuring testing across the board.
Yeah, we were using the HMIG discussions to flush out those issues.
We come now then to, if we can move forward, please, to May 2020. the inquiry has heard evidence about how at the heart of government there was an understanding that there was a need to change these ministerial official bodies, the MIG structure, and to put into place a new structure that could cope with the ever-changing and no doubt increasing demands of the COVID crisis. You were appointed Director General for Policy and Strategy on the COVID Task Force in May 2020, were you not?
Yes, I was.
In summary, what were the reasons for the change from the MIG structure to the COVID Task Force structure as you saw them to be in May 2020?
Yeah. I set some of this out in my statement, I think, and you have heard evidence previous to me about the ways of working in the Cabinet Office and Number 10 through some of this period. I think that a number of things happened through the second half of March and April that led to the need for change. I mean, the first was that it became increasingly clear that the combination of the 4 ministerial implementation groups and the 9:15 meeting created a number of overlaps. I mean, we talked about shielding. A lot of those issues were in the health ministerial implementation group, but some of the issues around wider support were in the GPS MIG. Take an issue like PPE. We were concerned in the HMIG about stocks. Actually, there was a big international set of issues about this because of the procurement from abroad, and there were issues in the GPS MIG about PPE for prison officers, schools, etc. And then secondly, because of the number of issues that ended up being discussed at the 9:15 meeting, there wasn't a sort of tidy funnel, if you like, from 4 MIGs to a sort of central strategy. So it became a kind of noisy structure over time. Equally, that meant for key colleagues in Number 10 and the Prime Minister, and indeed other secretaries of state and departments, it wasn't clear who was responsible for what a lot of the time. That was exacerbated by the fact that a number of us, in terms of the leadership in the Cabinet Office, got COVID through that period. So we were also, as we went through March and April, different colleagues were off for 2, sometimes more weeks at a time. So we were then filling in for each other, which sort of further confused the picture. And it became, to improve the efficiency with which we worked and the effectiveness with which we worked, a need to sort of bring all of that much more together, and crucially to be clear who was responsible for what. The second part of it, that's inside the Cabinet Office. The second part of it was that there was a significant degree of duplication between what we were doing in the Cabinet Office and some of the work being done in Number 10 through Tom Shinner and his team. And I worked closely with Tom in March and April on the relevant things, but we were parts of different units, and there was a need to bring that together. And in part because of all of this and because of some of the challenges of the working environment, there was a need for a bit of a reset. And that meant ending the arrangements that ran to the end of May and moving to what became the task force.
You referred to overlapping boundaries, a lack of direction, a lack of clarity as to who was leading in what area. And were there prosaically just too many meetings, too much time spent on trying to work out what discussions should take place at which meetings?
Yes, I mean, I think that is true inside the Cabinet Office. I think it was also confusing for colleagues in other departments because they might, if you have to go to most Cabinet Committee meetings are preceded by an officials meeting chaired by the Secretary or a member of the Secretariat team. If you're in the Department of Health and Social Care, incredibly busy across all of this, and you're trying to feed people for an HMIG officials meeting and a GPS MIG officials meeting and an international MIG officials meeting, then there was too much activity.
A profusion of officialdom.
Yes.
All right.
If you like.
The inquiry's heard evidence, Mr. Ridley, of a paper prepared by Sir Mark Sedwell, as he then was, to the Prime Minister, also of a paper prepared by Helen McNamara, who then became subsequently the Deputy Cabinet Secretary, called How We Govern. And I think there was a paper from Martin Reynolds and Helen McNamara on working practices. Were they the genesis for the establishment of the COVID task force, or was the genesis to be found elsewhere?
I think they were an important part of it. I think a number of conversations were happening and a number of things were happening coming from, a lot of the same places. And there was, as we went through, I think probably the end of April, certainly into early May, pretty much a consensus that we needed to shift the way we were working.
The COVID task force is described by you in your statement as a whole of government effort, and you describe how it led official advice in the centre of government. So the advice to the Prime Minister, the Chancellor of the Duchy of Lancaster, to ministers, and that it brought together all the policy and key issues required to respond to the COVID crisis. Is that a fair summary of the width of the COVID task force?
Yes, I think so.
All right. Can we have a look at 248852, which is your statement at page 10, paragraph 2.221. We can see from this paragraph, right at the bottom of the page, the task force had a number of focus teams working with other departments in a range of areas, while responsibility for delivery lay with those other departments and other relevant bodies such as NHS Test and Trace. The teams in the task force contributed to policy development and helped ensure that collectively policies were delivered effectively. So the COVID task force was the body at the centre, within the Cabinet Office, of course, which liaised with and worked closely with all the line departments and other bodies that were procuring equipment, delivering, I suppose you would call it, the policies, but the CTF brought it all together in the centre.
Yes, and I think I would. The COVID task force was different from the MIG secretariat teams, in that the MIG secretariat teams effectively were the secretary to the committee, and didn't do a huge amount other than bring information together, seek to push key priority issues, assure the centre and provide information and advice into the Prime Minister. The COVID task force had a broader remit. We did have a team that was the secretary to the COVID Operations Committee and the COVID Strategy Committee throughout the period. But we were a much broader team, also responsible for developing and getting agreed the overall strategy of the response and some key policy areas. The delivery was absolutely with line departments.
All right. Page 8 on this document, paragraph 2.14, we can see something of the links between the COVID task force to other bodies and other entities in government. You liaise with analysts across government, with SAGE, the subgroups, the CMO, the government's chief scientific advisor, Public Health England, ONS, Treasury, as you would expect, BIS and the Behavioural Insights Unit. You, I think, were responsible for 3 of the 6 groups or teams within the COVID task force. So you were responsible for vulnerable and shielding, strategy and roadmap, and policy. Do you think that the CTF worked well as an overarching body designed to replace the HMIG system and designed to improve what was then becoming apparent was an underperforming structure?
I mean, in summary, yes, I do. I think from the very beginning, reducing to a single team with a clear lead, which initially was Simon Case as the permanent secretary to number 10, bringing myself and Tom Shinner and a number of colleagues into the same team. So we had a single team at the centre. Did work. I mean, from May, we had to build the team up, and we had to develop the capability and capacity over a period of time. But it was a structure that endured from the end of May 2020 all the way through to spring 2022.
So it passed the test of time.
It passed the test of time, and I think we got more effective as we went on.
It obviously liaised very closely with the Prime Minister, number 10 staff, with central government. Did it also set up deep dive meetings for various entities and personnel in government to look at particular areas in real detail?
Yes.
And did it also, was it also responsible for providing dashboard briefings in number 10, so the provision of data across the COVID response?
Yes. I mean, the dashboard started earlier in the spring. It was run by the Civil Contingency Secretariat. We continued to develop that dashboard in the Cabinet Office. The dashboard passed to the task force, I think, in June. And from that period on, our data and analysis team presented that dashboard to number 10 and colleagues most mornings for the rest of the pandemic.
And you've mentioned the Cabinet Committees COVID-S and COVID-O. The COVID Task Force, as you say, was the secretariat for those meetings. Presumably it provided the agendas, it commissioned the paperwork, it organised the meetings.
Yes.
Give us some idea of the scale of the exercise. I mean, how many COVID-O ministerial meetings did the CTF arrange?
So there were a few over 200 COVID operations committees between June 2020 and 2022. It was the core ministerial forum throughout the pandemic in terms of taking advice for ministers to make decisions. It was it met through 2020, I would say, most days. It often met late. If we had to respond very quickly to issues, it often met at the weekend. We held an official meeting before COVID-O to make sure departments were involved in the development of the papers. A lot of papers were produced by departments. We didn't produce all the papers from the Cabinet Office, but there were some issues in which we did. So it was an absolutely critical part of the decision-making structure that was put in place.
And presumably there were thousands of actions ordered to be done as a result of the COVID-O meetings. Was the CTF responsible for those?
Yes, we were responsible for getting those actions out. We tracked those actions through the period, and we worked incredibly closely with number 10, the Treasury, other departments as necessary a lot of meetings led to agreement on policy, and there was a sort of subsequent announcement and the press notices or the guidance changes or everything else that went around that, and we were the people at the centre assuring ourselves that all of that happened as the government intended.
You refer to policy. Could you just give us an understanding of the division of responsibility between the various bodies as to the formulation of policy as to non-pharmaceutical interventions in the second half of 2020? So who or which entity provided the Prime Minister and COVID-0 and ministers with advice as to what should be done in terms of interventions? Was it something that was exclusively the domain of the COVID task force? Was it a matter for the CMO and the government's chief scientific advisor to communicate to the Prime Minister, or did responsibility lie elsewhere?
So, I mean, in terms of advice to the Prime Minister, official advice from the civil service to the Prime Minister on non-pharmaceutical interventions came from the task force. We developed that working closely with the chief scientific advisor and the chief medical officer, with, in particular, the Department of Health and the Treasury, often a wide range of other departments. Particular issues that came to COVID-0 would sometimes come from other departments, particularly the Department for Health. So I think we will come on to this, but some of the papers on tiering came from the Department of Health, for example, at the at points in the autumn. And then there were clearly discussions of some of these issues in other meetings between Secretaries of State and Secretaries of State. The Health Secretary or the Chancellor Duchy of Lancaster provided at key points in the year their own input to the Prime Minister.
Were there meetings of COVID-0 to which the CMO or the CSA, for example, contributed in the absence of the COVID task force? Or were there meetings with the Prime Minister where the Prime Minister received advice from the CMO and the CSA in the absence of the COVID task force? There appears to be a conduit by which information was provided to the Prime Minister, in particular from SAGE, through the funnel, the conduit of the CMO and the CSA. Was that a conduit to which the COVID task force was always party?
So there's quite a lot there. The answer to your question at the end is no. There was definitely a conduit of information from the chief scientific advisor, and the chief medical officer gave advice to the Prime Minister via electronic or personal means without the task force. COVID-0 as a cabinet committee was always secretariated by the task force. The CMO and chief scientific advisor were at most of those and inputted into those. We developed papers with them, but they would give their own views in the committee when asked or moved to do so. In other meetings with the Prime Minister, there were some which involved the task force and both the CMO and chief scientific advisor, and there were some, I am sure, but I wouldn't know, which involved them but not us.
My last question on this topic. Was the COVID task force concerned, therefore, that there were regular meetings or regular opportunities whereby the Prime Minister asked the CMO and the CSA and his closest advisors, perhaps, on what should be done, what practical steps should be taken to address the spread of the virus, and particularly in the autumn of 2020? In your absence, in the absence of the CTF, the body strategically and operationally concerned with providing advice to the central government concerning the proper response to the virus?
No, I don't think. Well, I was not concerned about that, and I don't think, as the COVID task force, we were concerned about that. We worked very closely with the chief medical advisor and the chief scientific advisor throughout the period. They were very generous with their time and advice for us, and it was not our role to provide scientific or medical advice to the Prime Minister. That was their role. It was our role to provide policy advice to the Prime Minister about the actions he could or should take in response to that advice, and indeed input from other government departments on a range of other issues. The Prime Minister certainly contacted Chris and Patrick to get their advice, but there was no point in the period where I felt we weren't either able to discuss with colleagues in number 10 the nature of the discussion, or to discuss with the chief medical officer and chief scientific advisor what they were saying. We attended SAGE, we read the papers, we had the minutes. That was all very much in the open, obviously.
That's a very convenient point.
I hope you're all that we take breaks, Mr. Ridley, and we'll break now, and I shall return at 11:30.
Thank you very much.
All rise. Mr. Keith.
Mr. Ridley, the data provided by the COVID task force, in your statement, paragraph 2.12 and 2.13, you say that the analytical capability of the task force comprised thematic teams covering health, science, economics, behavioural insights, social policy and public services, plus long-range foresight and data science functions. So, was the task force able to bring together data and information across the whole breadth of all the areas engaged by the COVID pandemic? So you weren't just providing scientific advice, for example, you were providing data and insights from across the range of these areas.
Yes, that is correct. Through the dashboard and through the broader work that we did, it's a capability we built through the summer and early autumn of 2020, but by the sort of October-ish 2020, it was probably about a team of about 100 strong doing that work.
Do we take it from that answer, Ms. Ridley, that until the early autumn, or rather in the months before the early autumn, the provision of data and information gradually increased until such a point where you were confident that your policy work and your strategy was fully informed by as much data and information as you could reasonably gather?
Yes, I think that is correct. We were using data and analysis as we went through the period, but the sources of data grew as time went by, and our ability to bring it together increased.
So, by way of an example, when advising in the autumn on non-pharmaceutical interventions, or what interventions generally the government could consider imposing, was the advice that the task force gave as informed by economic considerations and social considerations, as well as by the health and scientific ramifications of whatever it was you were advising?
Yes, I mean, to take a slightly, at each of the steps of the 11th of May 2020 roadmap, we provided advice to the Prime Minister and others about that opening up through the summer of 2020. That advice was informed by an assessment of the 5 tests in that May document, but we also added to that advice sections on the economic impacts and implications and the social impacts and implications, as well as the health issues. Similarly, as we got into the autumn, we were providing the information and analysis we had on the economy and society as well as on the NHS and the direct COVID impacts.
An important part of the overall data and analytical capability identified in your statement was the ICJU, the International Comparators Joint Unit. What was that?
So the ICJU was a partnership between I think the Joint Intelligence Organisation in the Cabinet Office and the Foreign Commonwealth and Development Office. It was a team that was brought together essentially to do a bit what it says on the tin, to provide international comparisons of different issues. It was incredibly important from the beginning that we had an international perspective and understood, what was happening in other countries and what the impact of different policies different countries were putting in place was. When Rob Harrison joined as our Director General for Analysis in October 2020, he'd been doing that work in the Cabinet Office, and we brought the ICJU much more alongside the task force. They produced a number of really helpful pieces of work. There was a recurring piece about MPIs and social distancing, looking at what different countries were doing, the kind of different stringency levels that different countries had in place, as well as producing reports on different specific issues as they came up.
So do you consider that the UK government was well sighted on how other countries were responding to the common threat of the virus and on the detail of the various strategies, policies and plans that they put into place?
Yes. And the ICJU wasn't the only source of that. Through the dashboard, we drew on other data sets about the growth of the virus, for example, or the path of the virus in other countries. So we were demonstrating where we were in terms of prevalence alongside other European countries and other countries at kind of all parts of the pandemic. We worked closely on key issues with ambassadors in various countries and working with the FCDO where there were specific issues that we wanted to dive into. So we had various means of bringing international comparisons to bear.
All right. Now I want to turn, please, to the position that confronted the government in the late summer, so late June and throughout July and August. As a result of the first national lockdown, if we may call it that, the prevalence of the virus was low, wasn't it?
Yes.
How quickly did it become apparent that the prevalence of the virus was ticking up, that infections were rising?
It was, as with these things, so it became clear in August, if you no, the key data we had at this point was the ONS infection survey, which had started up and which was an invaluable source of information as we went into the later part of the summer and into the autumn that had not been there in the spring. The ONS survey started to show a flattening off and then a small rise as we got into August, but a small rise from low levels, and that came through the dashboard. I also had specific discussions with Ian Diamond at the ONS and with Chris Whitty and Patrick Vallance, and there was a lot of discussion about the risk of opening up exacerbating that rise. I think on the data itself, there was uncertainty about the rate at which it would rise, and until we as we get into later August and September, it's sort of more clearly on an upward path.
there was a perennial risk or a permanent risk, a continuing risk, wasn't there, that as soon as the country opened up, the virus would reappear. So prevalence and whether or not the infections were beginning to tick up was of huge importance, wasn't it? You had to keep a very close eye on the way in which the virus developed thereafter.
Yes. And we did. I've just said something about the national level. We also did through the work that was happening in what was the JBC and Department of Health. We were seeing local outbreaks.
Just pause there.
Do you want to come back to that?
You say quickly JBC. Do you mean
Sorry,
the
Joint Biosecurity Centre?
Right.
But the information we got improved information via DHSC on local outbreaks. So as well as the national picture, we were very closely monitoring for the reasons you say. And it was actually, I mean, it was far back as June that there was the outbreak in Leicester.
I'm going to pause you there just
that.
because we're going to come back to the detail in due course.
Okay.
I just want to establish the level of concern in the late summer as to the re-emergence of the virus. Was it generally understood that viruses come in waves?
Yes.
And that as soon as the prevalence began to rise and the infections re-emerged, that there would likely be a second wave?
Yeah, so it was understood they came in waves, and there was, without question, an understanding of a risk of the second wave.
The whole debate in March, or at least late February, early March, had been how to deal with the first wave in a way that ensured that the virus didn't recoil like an uncoiled spring into a devastating second wave. So the whole idea of a second wave came as no surprise to anybody, did it?
No.
Throughout that late summer and into the early autumn, there was therefore this constant tension between the scientific and medical understanding that if you open up the country, the virus would likely re-emerge with great force, and the need to ensure that economically and societally the country could be returned back to something approaching normal as quickly as possible. That tension never went away, did it?
No. I mean, there was. I mean, the only thing that there was throughout a need to balance the requirement to suppress the transmission of COVID because of the direct health impacts of that, and the economic, social, and indeed broader health consequences of lockdown or very stringent non-pharmaceutical interventions. And that was the case throughout the 2-year period.
Could we look at an email from Tom Shinner, dated the 21st of June, INQ 174752, or not an email, I'm sorry, a document. Tom Shinner was part of the COVID task force, was he not?
He was at this point, yes.
At this point. This is addressed to Simon Case, who with you was effectively in charge of the COVID task force at this time in June. 14 weeks to prepare for winter. Page 1, paragraph 3, what follows is a straw man for your consideration and refinement. These are the biggest current barriers and suggest pursuing 5 operational and 5 organisational actions with immediate effect. Develop a contingency playbook, replenish stockpiles, enhance senior scrutiny on winter operational planning work, prepare a concerted behavioural influence campaign, retask the JIO. If we could just scroll back out, in paragraph 1, we can see Mr. Shinner says, I think we're more vulnerable to a second wave of COVID than is apparent. Was it generally understood in June that we were vulnerable to a second wave of COVID, and perhaps more so than was appreciated by some?
So I think we knew, and it was clear that we were vulnerable to a second wave of COVID. I think there was a question about the extent to which there was hope or optimism bias against that, but I think the risk of it was known.
In that paragraph 3 and also in the following paragraph, paragraph 4, we can see Mr. Shinner makes a number of recommendations. In relation to the organisations, he suggests rehabilitating and reforming Public Health England, restaffing key leadership roles, defining clearer responsibilities across government, developing a central analytical function, redesigning the COVID task force. To what extent were any of these practical suggestions adopted? Do you recall?
So so do you mean specifically paragraph 4, or
yes.
do you mean the note more broadly? So a number of these in paragraph 4 were adopted. The organisation of the various new structures in DHSC, i.e. Test and Trace, and the Joint Biosecurity Centre and PHE were ultimately brought together. I can't talk with authority about staffing across all of government, but there were a number of places where senior staffing was strengthened, including in the COVID task force, where we recruited Kate Josephs as a Delivery Director General, succeeding Tom, and then Rob Harrison, as I've said, as a Director General responsible for analysis. We worked very closely from the COVID task force across Whitehall. I chaired very regular meetings with Directors General across departments, and indeed there was a regular Cabinet Secretary-led meeting for 2020. We didn't bring other departmental leads physically into the same team. We maintained the task force is structured in the Cabinet Office. As I've talked about, number 4 was done. We didn't restructure the COVID task force precisely as Tom describes here, but we did reorganise it as we went through the summer after Kate arrived, and we brought more capability. I can talk in more detail if that would be helpful.
That would tend to suggest that the COVID task force was on top of its game. It was aware of the need to perfect the position, perfect the system in order to prepare for the inevitable second wave.
So we certainly. I wouldn't want to overstate in terms of perfection, but we had learnt a lot in the spring. We wanted the COVID task force to be in as strong a position in the centre of government as possible, and we wanted to be working with Whitehall departments and with others to be prepared. And we were doing a lot of work through the summer to that end, in terms of work on MPIs and how we could develop them, in terms of scenario planning and some sessions that we had with number 10 colleagues and the Prime Minister and others through the summer.
All right. 265766, please, at page 3. This is a communication on WhatsApp between yourself and Simon Case. We can see, thank you very much, at 21:22, Simon Ridley spoke to CMO and Patrick Vallance about next steps. They caution against doing much at all beyond outdoor sports arts this month before seeing impact of the weekend changes. Their other big worry is keeping headroom to reopen schools safely come September. So the scientific and medical advice, if you like, from that quarter was very much towards making sure that the country didn't open up too much, too rapidly, that there was a constant risk that if things were opened up too much, it would allow an opportunity for the virus to re-emerge faster than would otherwise be the case. That was the debate.
Yes, I think absolutely. I think the other point that this is a very brief summary of was that seeing the impact of changes took time. and they were cautioning against putting change upon change before knowing where we were.
In general terms, in the summer, was the policy and the course adopted by the government in line with the CTF's own views as to what should be done cautiously, safely, and in such a way as not to allow the virus to re-emerge?
I mean, so we were bringing this view together. There was also in a number of departments around Whitehall a desire to get sectors reopened. There was a significant economic and social cost to the length of time different sectors had been closed. So in the task force, we were trying to understand that and the implications of that, and develop, guidance around being COVID secure, for example, to enable opening up to mitigate these risks that the Chief Medical Officer and the scientific advisor were articulating.
We appreciate the CTF was trying to understand the significant economic and social costs and work out the balance between the costs of intervention and the costs of the costs on society at large of those interventions. But in a general sense, was what the CTF was recommending in terms of the general strategy of the government, the general course, that which the government actually adopted?
So we were governed through the summer by the 5 tests in the May 2020 document, which were about the capacity of the NHS, about our readiness on kind of operationally on issues like PPE, about the direction of the virus, and we were couching our advice through that. We were certainly in our advice seeking to minimise the risks of a significant second wave, but we were balancing that against various other issues and in general advising a course consistent with.
So in the CTF's role as bringing together in one body the policy and strategy for responding to COVID and for liaising with and synthesising all the data and the approaches from the line departments, what was the CTF's view on the Eat Out to Help Out scheme?
The Eat Out to Help Out scheme didn't come through me or the task force. It was decided by the Prime Minister and the Chancellor, as far as I am aware.
So the COVID task force, by August, had been in place. It had been formally announced in June, but you'd been operational since May. You were the single body tasked with synthesising the policy and strategy for responding to the virus and giving advice to government on how it should be responded to. But you did not advise on, you did not comment on, you weren't even asked to consider the merits of the Eat Out, Help Out scheme.
That is correct.
When you first discovered that that was what was being proposed by HMT, what did you do?
I mean, I think I can't recall exactly the first things that we did. I mean, I think to be in terms of my role, internalise that as government policy, and what that meant alongside the other decisions that we were taking. I don't recall that there was at that point a prediction, if you like, of the impact of it over the next few weeks, but it obviously factored into future advice.
Mr. Ridley, you were shortly to become the leader of the CTF. I think you and Mr. Bowler and Mr. Case were the driving forces behind the CTF. You were in charge of the body which was convened, designed, operated to bring together at the heart of government all the policy and the strategy relating to the response to the virus. you must have been extraordinarily concerned that a major plank of the government strategy, a positive scheme to financially support people to eat out across those midweek days in August, had not been brought to you for your views.
I mean, things happen that surprise. I mean, we were focused on the advice we could give in the context of the steps of the May 2020 document. This was announced as government policy. I didn't spend time worrying particularly about the whys and wherefores of that.
Because you were effectively completely blindsided by the Treasury and there was nothing you could do.
Correct.
All right. The Covid-19 recovery strategy was published on the 24th of July 2020. Could we have INQ 137239, page 1, and then page 5, I think, for the index. Suppressing the virus, opening up society, continuing our plan to rebuild. On page 13, at the third paragraph, there is a reference to the government undertaking preparations to make sure that we are as ready as possible for the risk of a resurgence in the virus between November and March. Did the CTF have a hand in the preparation of this document?
Yes, we were, the lead drafters of this document.
What preparations was the government undertaking? What in practice, what in reality were those preparations? Can you give us some idea?
Yeah. So the government was continuing to build the infrastructure and capacity of the test, trace, and isolate system led by Dido Harding Department for Health and Social Care. We were doing lots of work on local interventions, again, led in large part through the HSC, but we were bringing that together with other government departments. We did a lot of work under the banner of smarter MPIs to try and explore different ways in which it might be possible to reduce social contact and suppress the virus with less economic or social impact, and several other things besides. I mean, there was tons of work on the vaccine going on, for example, although we were not expecting that by November. We were hopeful we would have, as indeed we did, vaccine in place by March.
Putting aside the vaccines, which obviously are a huge topic on their own, and putting aside the test and trace, which of course was led, the NHS test and trace by that stage was led by Baroness Harding. What preparations in practice were being made in terms of, as you say, exploring different ways in which it might be possible to reduce social contact and suppress the virus? Do you mean papers or policy documents were drawn up saying, well, there is this tension between suppressing the virus and continuing to damage the economy? Or do you mean there were policy documents identifying particular NPIs or restrictions which could be contemplated in the future? What did that policy consist of?
So that's what we had been looking at through June and July, very much in the context of the very significant social and economic harms of a national lockdown, and wanting to be as prepared as possible as we went into the autumn for how we could mitigate a second wave without having to do a subsequent national lockdown. In terms of the practical things we were doing, we ran a piece of work, as I say, under the title of Smarter MPIs, to explore what the possibilities were. That involved colleagues from across government, particularly health, the Treasury, and others. We were looking at ways in which, for example, we can encourage safer behaviours from people. We were looking at enforcement and compliance with regulations. We were looking at the possibilities of how we could use local interventions rather than national interventions. We did a big piece of work on it's called segmentation, which is essentially a sort of if you like, a kind of harder and broader form of shielding is one way to think. So is there a way of protecting and if you like, restricting the movement of more vulnerable portions of society and letting those less likely to suffer severe consequences of COVID to go about their lives more normally?
Just on this subject of segmentation. So in essence, part of what had hitherto in February, March been the mitigation strategy, which was trying to see whether or not there were parts of the population who could be segmented, safely contained, in a way that would protect them in the event of a re-emergence of a second wave.
Yes, and through a second wave.
Your statement makes plain that there were two occasions when the government dug down into the issue of segmentation after the first wave, firstly in September 2020 and then at the end of 2021 with the Omicron wave. Why in September 2020 was it decided that measures for segmentation were impracticable and therefore not to be pursued?
So we did a detailed work. We did this very much jointly with, in fact, I think Treasury seconded a colleague into the task force to support us to do this work. Very much a joint piece of work. The reason why a sort of, if you like, a kind of hard form of this we didn't think could work was a combination of practical reasons. It just keeping people away and isolated from the virus for a long period of time is ultimately sort of just practically too difficult.
Just pause there before we come to the second part. But was not the idea of segmentation merely a revised or recalibrated form of shielding? In the early part of the year, the government had been able to put into place a practice whereby you described it as low millions, but low millions of people in the population were effectively and well shielded. So wasn't segmentation just a variant of that?
So in a way, in a way, yes, but it was broader and deeper, and the purpose of it was to allow, if you like, life for others to go on broadly as normal, whereas we were preparing shielding to protect people, including through a lockdown where there was much less social contact. So the prevalence was going down. The idea of segmentation was to enable people to be away from a virus when it was running rife, potentially for much longer, because those people who were not segmented, if you like, were going about their normal business, and you would expect a very high level of transmission of the disease between those people.
How seriously was segmentation considered? You're aware, of course, of the debate surrounding the second lockdown as to whether or not a lockdown was avoidable, inevitable, whether or not there was an alternative path that could have been adopted whereby a segment of the population were segmented.
Yeah.
In this work in September, to what extent did you seriously consider segmentation and satisfactorily resolve that it wasn't possible?
So, I think we did the detailed work from August. We did I think a substantial piece of work through that summer. I recall I put a detailed piece of advice up to the Prime Minister, I think in September, where there were various products as a result of that work that came about from talking to, colleagues across Whitehall, to the Chief Medical Officers and his deputy, his deputies, to the Chief Scientific Advisor. We were learning from shielding, and indeed it was clear by that point that there were some benefits to shielding, but there were also some real downsides to shielding and from being isolated for a long period of time without access to people. So we took all of that into account, and we thought about what would happen. How do you come out of how would you come out of segmentation, and how realistically can you kind of get to that point? So it was a detailed piece of work, and I think we were confident at the end of it that being a strategy through the wave would be unlikely to succeed on its own terms.
Just help us more with the reason why it didn't or couldn't work. Are you, by reference to the issue of the real downsides to shielding and from being isolated for a long period and what would happen, referring there to the practicalities? How do you physically segment 1.5, 2 million or more people? Mindful that, of course, you had successfully shielded a very large number of people in the spring. Or are you referring to the more conceptual issue of, well, is it feasible to make people segment themselves and to be segmented for such a lengthy period of time? That is to say, the period of time required to be segmented whilst a second wave washes through.
So I think both of those. I mean, to take a practical example. I mean, there are an awful lot of mixed generation households in the country, or households where there is one person who is clinically extremely vulnerable. If you've got a household where one or two people are, if you like, need to be segmented, others are going to work or going to school or going shopping, to the cinema, etc. They come back home. If that home has only got one bathroom, they're all manner of just the idea that the virus there could be a barrier between one half of society and the other half of society, which this virus is going to very rarely cross. We could not see a way in which you could practically manage that sufficiently.
There was never going to be a hermetic seal. There could never be a hermetic seal. That barrier would always be permeable. But in the spring, the government had been able, in practice, to provide a measure of protection to those persons who were shielding, because they had food delivered, they had medicine delivered, they had services provided, because they were, in practice, being segmented. Why couldn't that have been done again with the requisite political will? Why couldn't that have been done in practice?
We were doing that in March through a period of a national lockdown, while prevalence was coming down and people were not going to restaurants, pubs, shops, etc. The premise of shielding was that we wouldn't have to cause that social and economic harm because the rest of society would be left open, and therefore you would have very high levels of prevalence while you were trying to maintain the safety and separation of the segmented population. So I totally agree. We didn't put up a straw man of a hermetically sealed border, if you like, or boundary. But the context this was being thought of was not the same as the context of shielding in March, and how do we give people that extra safety at a time when we're trying to manage the virus down.
But the persons who were shielded in the spring were, of course, physically and mentally isolated by virtue of the national lockdown.
Yes.
And of course, by the necessary isolation brought about by the need to be shielded. In the autumn, it would have been possible, or it could have been possible, to put into place a revised system of shielding, of segmentation, because you had the practical measures in place. But was it thought that because of the general prevalence of the virus in society, even that degree of shielding, being segmented, would be insufficient to protect those individuals because the virus was rampant in society, that it just wouldn't work in terms of protecting them? Is that the thinking behind the decision?
Yeah, essentially, we did use advice to the clinically extremely vulnerable, and indeed there was clinical advice about who the right groups of people were through the autumn and indeed into 2021. We did use shielding. The point was we didn't think that was a way to avoid other MPIs and enable the rest of society and economy to go on as normal.
But if the level of prevalence, if the degree of infection in society had been able to be brought down somewhat from the highest possible level, perhaps by tiers, perhaps by regional firebreakers or whatever it is, why couldn't, with a slightly lower or a significantly lower prevalence, segmentation not have been introduced in the autumn in order to avoid the consequences of a full national lockdown?
So, I as I say, the conclusion of the work we did was that we did not think it would be possible to manage the virus and the pressures on the NHS through segmentation as our primary strategy. We did use shielding alongside other MPIs, tiers, etc. That is, and local restrictions. That is where we got to as we got to September, October, November.
On the 16th of September, there was a meeting with the Prime Minister attended by the Chief Medical Officer and the government's Chief Scientific Advisor. I don't think I have available the notes of the actual meeting, but from a readout note prepared by Imran Shafi, it does seem that there was a considerable debate about the reasonable worst-case scenario, and that with no action, the United Kingdom could again see deaths running at 200 to 500 deaths a day. Were you present at that strategy meeting on the 16th of September?
Yes, I think I was. If it's the meeting in the afternoon of that day, I think that was a meeting which was an opportunity for the Chief Medical Advisor and the Chief Scientific Advisor to give their views on where we were to the Prime Minister.
They were obviously setting out the basic position in terms of what might happen if no action is taken. Was there any debate, though, about specific policies or specific measures which might be contemplated? For example, circuit breakers or regional fire breaks, or however you might want to call them.
I don't recall in detail. It wasn't a meeting that we put propositions to or sort of to the papers to. It was mostly to discuss the context and where
you were heading,
where we were heading, and where we were and where we were heading, and where this might get to over the coming weeks. I'm sure there will have been discussions of particular measures, but it was not a meeting to decide those sorts of things.
It seems from Mr. Shafi's notes that the Prime Minister asked to explore, quote, a range of views from different scientists. Do you recall the Prime Minister asking to hear a range of what might be described as alternative views from other scientists?
Yes, I think I do. I think it came out of that meeting.
Did you ask or did you ponder why he was seeking those views when he had, of course, the benefit of advice from SAGE, communicated through the CMO and CSO, and all the work, the policy and strategy and data from the COVID task force?
not beyond thinking it was, why not bring a wide range of views in? It was important to understand perspectives. If the Prime Minister wanted different voices, then should just put that in place.
But there was no area of data, policy or strategy which hadn't been considered by you, the COVID task force, and the combination of the CMO and CSA?
No, but there was a more contested debate about the right approach in terms of government action to suppress the virus. There was a greater variation of approaches by different countries in October than there had been in March. And we were at a point in time where there was a kind of increasing, risk of a second national lockdown, which the government wanted to avoid as much as possible. So understanding the broadest range of views, I mean, we provided a wide range of advice from the COVID task force, drawing on a number of different people. But I wouldn't say we captured absolutely every point of view and were able to present.
The scientists whom the Prime Minister ultimately met included Professor Gupta, Professor Hennigan, and the general proposal, which was put before him subsequently, in fact, at a meeting on the 20th of September with them and Mr. Tegnells of Sweden, the state epidemiologist, was that it would be possible, or it was possible, to have a structure whereby a large part or a proportion of the population was indeed segmented, and that this was a proper and useful way to avoid the calamitous consequences of a lockdown. And that approach became known in part, or a variant thereof became known as the Great Barrington approach. At that meeting on the 16th of September, did the Prime Minister call for a range of different views because the notion of segmentation had already been essentially turned down by the COVID task force at that time? You had advised on the 7th of September that you didn't think it would work. Was this call by the Prime Minister a reflection of his frustration at the fact that segmentation had been practically excluded by the COVID task force?
I think you'd have to ask the Prime Minister. I don't think I can answer that. But it was certainly the case that we were, the Prime Minister and other secretaries of state were seeking ways of managing the virus short of a national lockdown, and that we were operating in a context where we were looking for ways through short of that in terms of restrictions, for sure.
On the 19th of September, the COVID task force submitted an advice, the winter strategy advice, to the Prime Minister. Could we have, please, 137293? It's a document from you dated the 19th of September. Paragraph 1 recognises the infection is spreading rapidly. The 7-day average of confirmed cases has risen from 1,077 in mid-August to 3,600 odd today and is on a sharply upward trajectory. Hospitalizations are increasing. The SPI MO's view is that if no further measures are implemented, such a high level of hospital admissions has the potential to overwhelm the NHS in around 6 weeks. So 6 weeks from the date of this document, the 17th of September, it is essentially the end of October. Is that correct? The Prime Minister was presented with a number of options. If we look at page 2, paragraph 4, you could decide to take minimal action now, but with a plan to intervene a couple of weeks hence if the numbers continue to deteriorate. But any intervention is likely to take 2 or 3 weeks to have an effect. Infections will continue to grow during that time. If we look at page 3, we can see package A, double down for the winter, which had these were the least stringent measures, were they not? National address, publication warning, guidance to work at home if people can, more enforcement, hospitality table service only, tweaks to the rule of six. I think the rule of six had been introduced on Monday, the 14th of September, had it not?
It had.
But paragraph 7, the view of the CMO and the Chief Scientific Advisor was that unless it prompts a significant behavioural response, package A is very unlikely to drive R below 1. Package A, by use of those words, very unlikely to drive R below 1, was therefore never really very likely to work. And was it sensibly pursued? Was it advanced sensibly as a practical option?
So I think the meeting that discussed this note was the morning of the 20th. And we discussed the trajectory, and we discussed actions that could be taken, very much in the context that to drive R below 1, we would need to go further than package A.
The whole point of this meeting was to debate what could be done to reverse the potential exponential growth of the virus.
Yeah.
Why was package A even contemplated if it was very unlikely to drive R below 1?
So, I mean, the first thing to say is there's obviously a huge amount of uncertainty in what we were trying to do, which is ultimately to prompt a significant behavioural response. So over the course of the summer, we'd been opening up. People were starting to do more, and the question was, we had in place a load of measures not covered here in terms of the local restrictions in areas of the greatest outbreaks, and the overall strategy the government was pursuing was still focused on local outbreaks, addressing local outbreaks, testing, tracing and isolating, and prompting compliance. The question was, what level of further national action could prompt a behavioural response that shift people back towards avoiding more social contact? Absolutely. So package A was here as, if you like, an absolutely minimal amount of stuff that needs to be done and minimal amount of measures that need to be taken for the next few weeks. But you're probably going to have to go further.
So it was a make weight,
if you like.
Do you have any views, perhaps with hindsight, on the propriety of advancing a make weight package?
I'm not sure that's a fair question, Mr.
All right.
Keith.
Page 5, paragraphs 11 and 12. In the context of package B, this package would be more significant than steps taken in France and Spain. Both countries are recording around 10,000 new cases each day. Deaths are rising. And 12, in addition to this package, the government should develop a proposal for a much more severe enforcement policy. That package B is set out at paragraph 14 on page 5, I believe. Measures for the duration of winter, reduce household mixing, reduce the number of exceptions to the rule of 6, close hospitality 10 p.m. to 5 a.m., and then page 6, paragraphs 16 to 18. Impact on the hospitality sector, more stringent than other European countries, but at 18, there is a risk that even a combination of A and B would fail to bend the curve, leaving R above 1. So without answering, I'm just setting out the framework. Package C on page 6, 19 to 20, harder temporary measures. Ban all contact between households in all settings except for work. Advise against travel, closure of leisure and personal care sectors. Was that the circuit breaker?
Essentially, yes.
Right. So the CTF suggested, A, a package which was very unlikely to work if the aim was to reduce the R below 1. Packages B and C, in relation to which you were recommending that a combination of B and C would probably have to be imposed in order for the strategic aim to work. Is that correct?
Yes. I mean, we were laying out the trajectory and that we were on and different ways of changing it.
There was no suggestion in this paper of the tier approach, was there?
No, not explicitly. Right. That debate was
in October.
Well, tiers were being debated in September because we already had multiple local restrictions in place across the country, and there was a need to regularise that.
In October, a system of tiers was introduced, was it not? It was debated, promulgated, announced, effectively regional lockdown measures. And it's obvious that that was a step short of a lockdown. Why wasn't a tier package suggested as part of packages A, B, and C, and therefore advanced as a way of introducing another form of relatively stringent intervention, but short of a lockdown, that might have helped to reduce the incidence levels of the virus?
So, I mean, I think the end of this note mentions regional circuit breakers. We were debating how to regularise the local restrictions in place at this point. I mean, this note was mostly focused on taking a degree of further national action following the introduction of the rule of six, as you say, a week or so earlier, to increase the suppression of the virus at a national level alongside the local restrictions that were in place.
Mr. Ridley, standing back, in September, these packages are proposed. Around about the middle of September, there is a rule of six imposed. Following this meeting, the Prime Minister goes for a mixture of B and C.
A and B.
Sorry, you're quite right. A and B. So he goes in part for a package which has been described as very unlikely on its own to reduce the R below 1. And he takes part of package B. He takes no part of package C. And that is what is announced. Essentially, curfew at 10 o'clock and some other aspects to do with enforcement and publication and communication and advice. It doesn't work. And in October, the government introduces a tier system, which we'll come on to in a moment. And that doesn't work. And we end up in a national lockdown. Why wasn't that tier system, which might be thought to be short of a national circuit breaker, but is undoubtedly more stringent than curfew and restrictions on hospitality, considered in September, as a result of all the policy work that the CTF has done, considered and debated upon, so as to give rise to the possibility that had something more stringent than this been considered in September and imposed, there may not ultimately have been a need for the lockdown that was ultimately imposed.
So, I don't recall why we haven't discussed tiering as such in this note, other than the work on local lockdowns was, if you like, already agreed and in the sort of baseline of what we were doing. We were having a discussion about how to regularise that into tiers so there wasn't the plethora of different arrangements in different parts of the country. This note was focused on further national action in the main that could be taken, because while the growth of the virus and the outbreaks were still largely at a kind of local and regional level, there was concern that in areas with lower prevalence it would grow over time. But
the tier system, whilst having an impact regionally, because obviously it worked by way of putting every region into one or more, one tier or another, tiers 1, 2, or 3, was a national system. It applied across the whole of England.
Yes.
So,
But at different tier 1 was considerably lower than a mixture of than some of the things in package A and B.
yes, but your answer was this note was focused on national action in the main that could be taken. The tier system was a form of national action, was it not?
Yes, I mean, it was a national system.
Right. On the 20th of September, the COVID task force supplemented this advice by presenting the Prime Minister with hypothetical scenarios of what ministers might be faced with in October if the virus was not brought under control. Correct?
Yes.
Could we have 146611? So we can see from the top right-hand corner the action, submission to Prime Minister on 14th of October. This was and the document emphasises it's hypothetical thought experiment, not government policy. This was a hypothetical scenario put before the Prime Minister, in effect to tell him, if you don't take certain steps, then by the 14th of October, these are the sorts of problems or crises that you may have to confront.
Yes.
Right? Why was it necessary to put that in front of the Prime Minister? And bluntly, scare him or hypothesise as to what terrible dilemmas he might have to face in the future if he didn't take a decision in September the way that the COVID task force believed he ought.
So we were trying to find ways to make sure we were having a debate about the policy decisions needed today to impact where we would be in several weeks' time. There was an enormous amount going on every day, and there was uncertainty in trajectories and all these sorts of things. And the purpose of this meeting was to try and kind of create the space to say, essentially, if we don't act now, this is the conversation we might find ourselves having a few weeks hence, and the sorts of decisions that would come about.
But he's a Prime Minister. You had given him a strategy document in September saying these are the packages which we want you to consider. Which one do you want? Well, why do you need to hypothesise as to future yet to be future eventualities which have yet to come to pass?
I mean, what we were trying to find, as I say, different ways to have the debate with the Prime Minister and others about the uncertainties, about the possible positions we could be in, and about in order to inform decisions about action today. And we found at different points in July, August, and September that doing meetings in some slightly different ways, that providing information in different ways helped to stimulate that debate, and that's what this was about.
Or prompt action?
And prompt action.
If you'll allow me to say so, quite so. You had, or the CTF took a view, did it not, as to the merits of the various packages being presented to the Prime Minister, and attempted to have, to use your words, that debate with the Prime Minister in a way that accorded with the CTF's approach. You hypothesised a worst-case scenario in order to influence his decision-making. Is that fair?
Well, in order to make sure we were providing advice in the best way that we possibly could. There is a meeting on the 7th of October where we recommend essentially regional circuit breakers, which I don't know whether we will come to that or not. We could see, the path of the growth of the virus, and we were trying to make sure that the implications of that were part of the decision-making process. There were things weighed against this, which are about, the economic, social costs of more stringent MPIs.
The Prime Minister met with Professor Gupta, Professor Hennigan, Anders Tegnell of Sweden, and Professors Edmund and McLean on the 20th of September, on the Sunday. Were you aware, or were you made aware as the head, I think very soon to be, of the CTF, of the outcome of that meeting?
Yes, I listened to that meeting.
Meaning you were there?
I can't honestly remember if I was in the room or on the end of a phone. There was a train delay that day, but I listened to the meeting.
Following the meeting, the Prime Minister's conclusion was to pursue all Package A nationally, and some measures, as you've said, from Package B, including the national curfew from 10 p.m, options to tighten face mask policy, and a call for tighter local restrictions. If the scientific advice and the advice from the CTF is Package A would be very unlikely to reduce R below 1, and if the government was following the science, why did the Prime Minister not adopt a combination of B and C, or C or B, as opposed to pursuing all of Package A and only some measures from Package B?
I think that's a question for the former Prime Minister, Mr. Keith.
So I think that is a question, thank you, my lady, for the former Prime Minister. But it was clear from all the discussions I was in that he, and indeed his colleagues, were balancing a series of different harms and a series of different risks in the measures that they sought to put in place through that autumn.
But your earlier evidence was the fact that one of the primary roles of the CTF was to bring together all those other considerations, the economic, the social, the health, and so on and so forth.
Yes. And that is what we sought to do, but we've got all we can do as the COVID task force is give advice.
All right. So you did indeed give advice to the Prime Minister, further advice on the 7th of October. We'll have INQ 198158. Policy package. We recommend that the package should be applied to the North West, North East, Yorkshire and Derbyshire in part. The proposition summarised in Annex A for 4 weeks. The prohibition of social mixing indoors in private gardens, closure of hospitality, closure of indoor leisure, closure of personal care services, weddings, standalone ceremonies not permitted. Were these the regional lockdown measures?
Yeah, this is effectively, in the parlance of the time, a regional circuit breaker.
Page 2. There is a choice on whether to tighten social restrictions further, A, B, C, and D. We recommend option A against any tightening. And then I think there was there a map?
Yes.
Well, an annex which showed those parts of the country which would be subject to these regional lockdown measures. If we go back to the first page, was this a document that came from the CTF?
Yes, there was this document, there was a map, as you say, and I think there was a third document that described the process we could go through to put this in place in about a week.
There was a meeting on the 8th of October, shortly thereafter, INQ 146616. And after the meeting, at which the Prime Minister had met the Chancellor, the CMO, the CSA, and the NHS CEO to discuss COVID and NHS preparedness, this readout refers to, well, the general course of the debate in that meeting. What was the general tenor of the advice being given to the Prime Minister epidemiologically? Was it made clear to him? Was it said to him, the NHS is going to be overrun. The second wave is coming. Unless these steps are taken, there will be no prospect of avoiding the NHS being overrun. How was it pitched?
So I think so there were two parts really to the meeting, as I recall it. The first part was focused on NHS capacity and the extent to which the NHS was either then or likely soon to be overwhelmed, which the NHS chief executive spoke to as recorded here. I think my recollection is that nationally at that point the NHS was not overwhelmed, but there were some very clear regional pressure points, particularly in the northwest, as I recall. But it was certainly getting more pressurised, and there was no doubt that the prevalence of the virus was increasing, and the scientific advice that was without action now, we were likely to need to take further action soon. And then the second part of the meeting was more about the non-pharmaceutical interventions, which was a debate about the level of confidence we could have that they would have the suppression effect that we were saying they would.
On that first part, we can see in the bottom third of the page, Simon Stevens argued that, stepping back, not everyone currently accepted there was a problem. People did not think measures were fair. They questioned whether they worked, and if they did work, they wanted financial support. Government response should take these factors into account. Was the position with the NHS being presented on the basis that it was as bad as it had been in March? That is to say, unless measures are taken rapidly, it will be overrun? Or was it presented on the basis that it's going to be extremely difficult for the NHS, but it's not as clear as it was in March that the system would break?
So my recollection of at this point was that the NHS was under enormous pressure. It had some more capacity than it had in March. At a national level, it was coping, but there were some regional areas and some particular hospitals under enormous pressure. More broadly, and I think the comment you have drawn attention to, the debate about severe restrictions, lockdown, circuit breakers was certainly much more contested in October than it had been in March, and there was a strong view of across different parts of the country of not wanting to have stronger measures than their part of the country, in their view, required.
But putting aside the undoubted damage that would be done by a further lockdown, putting aside the economic arguments and the arguments about the societal harm that would flow directly from a lockdown, and of course the impact on particularly vulnerable parts of the population, in terms of the NHS, the position was not as acute as it had been in March, was it?
No, my recollection is that it was not.
And the Prime Minister, therefore, wasn't presented, was he, with a unanimous call for measures, these regional circuit breakers, these tiers, to be imposed in order to avoid a collapse of the NHS? That just wasn't how it was framed.
So I think the meetings were, and there were not just this one, there were other meetings where the position in parts of the country was becoming acute, and the advice would become at risk. I recall Liverpool in particular at this point was at risk of being overwhelmed in due course. We were also doing, working very closely with colleagues in Number 10 to seek to understand, where that the sort of point of overwhelm, if I can put it, might be for the NHS and how close that was. That was inherently very uncertain.
The Prime Minister was grateful for the contributions of all and said he would discuss further with the Chancellor before agreeing a final approach. Having been present at the meeting, were you given to understand why he wanted to discuss this with the Chancellor, what was essentially a national decision, a public health emergency decision? Did he say why he wanted to discuss it with the Chancellor?
I mean, I think some of that is captured a couple of paragraphs up. The economic consequences were very much at front of mind. I think there was also a discussion about the financial support to local areas at this period, which the Prime Minister and the Chancellor, as a public spending measure, wanted to discuss.
That debate with the Chancellor is in 252865.
It doesn't look as if we're going to finish, Mr. Ridley.
No,
and there are some questions from the participants.
I'm
Mr.
afraid
Ridley, are you all right to come back this afternoon?
I don't have anything else on, my lady.
I'd take that as yes. Thank you very much. I see what you mean. I've just worked out what your answer meant. I'll return, if you don't mind,
No,
Mr. Ridley, at
of course.
1:45.